Hello friends, so welcome back to my channel Medicine 101. Today we will talk about junctional arrhythmia, or we can say the Av nodal arrhythmia, or we can say the nodal arrhythmia or the junctional arrhythmia. Okay. So before starting the video, let me tell you I have already uploaded the video, the normal cardiac arrhythmia in terms of the introductions part. Then I did upload the sinus arrhythmia. Then I did upload the video on the based on what? Atrial arrhythmia. Then I'll talk about what? Junctional arrhythmia or the Av nodal arrhythmia. Then I'll subsequently upload the video ventricular arrhythmia. Okay, so let's continue. So try to understand from here, from this figure. If I just consider this is the heart, we'll get the what? We'll get the AC node over here. So let's write the name of it. We'll get the AC node from here. Then we'll get this is the what? AV node. So we'll get the AV node, this position. Okay, now see. At first we know that AC node is having the what? High automaticity. That means they can go under the spontaneous depolarizations. So whenever they will go under the depolarizations, they will send the electrical impulse or the cardiac impulse through where? Within the atrium. And from atrium it will come where? Within the AV node. Try to understand from here these parts. Okay, this is the what's the ring? This is the fibrous rings over here. So this whole fibrous rings is what? Electrically insulators. So they cannot conduct the electricity or the cardiac impulse over here. So only thing that is left over here that can connect the atrium with the ventricle, that is the AV node. As I said that what? The fibrous part, they are not able to conduct the electricity as they are electrically insulators. So they will be not able to conduct it, the electricity or the cardiac impulse. So what is left over here? Only the AV node. So the AV node that will conduct cardiac impulse from the atriums to the ventricle. Okay. So you can write it over here that from the AC node, the electrical impulse that will come where? Within the AV node. Within the AV node. Okay. Now, as I said also you before that the conduction velocity, within the AC node, that will be moderate velocity, and within the AV node, what? The velocity that will be what? Slow. We'll get the slow velocity, or you can say the conduction that will be slow where? Within the AV node. Why the velocity will be slow? I'll talk about in subsequent minutes. Okay, I'll talk about these things within a couple of minutes. Why the conductions within the AV node that will be slow, and what about these things? The bundle of Ridge and the Purkinje fibers, and ultimately we'll get what? The ventricular myocardial cells over here. So the velocity for this thing that will be what? Fast velocity. The fastest velocity in terms of the cardiac conductions will get where? Within the Purkinje systems on the bundle of Ridge. Okay, so let's write it over here. So after AV node it will come within the bundle of Ridge. Then we'll get within the Purkinje fibers. Then we'll get ventricular myocardial cell that will go over there. Now try to understand that, as I said, the AC node, within the AC node, the velocity that will be moderate velocity. If I say in terms of the AV node, the velocity that will be slower. And in terms of the the bundle of Ridge and the systems within the ventricle, so bundle of Ridge, for example, the other parts also along with this. So here we get the fast velocity. Now why we get the velocity within the AV node slow? Try to understand whenever the electrical impulse is coming from the AC node to the what? AV node, at the time the atria they will just start contracting. Whenever the atria they will start contracting, okay, after the completing of the atrial contractions, whenever the atrial contraction that will be completed, after that what? There will be onset of what? Ventricular contractions. Now whenever the electrical impulse will come from the AC node, that will be held where? Within the AV node for a while. So from AC node, whenever the electrical impulse that will come within the AV node, here the electrical impulse or electrical current that will be held or held, whatever you can say over, that will be held for point on second. So why it will help? Why the there will be the holding of the electrical impulse over here. Try to understand that this AV node, by holding the electrical impulse, it will help the atrium to contract completely. So it helps the atrium atrium contractions completely. Okay, try to understand from here. Whenever the atrial contraction that will be completed, the blood from the atrium that will be sent within the ventricles. Okay. Now we'll talk about why we'll get the slower contractions within the Av node. Why we'll get the slower contractions within the Av node. Okay. Now let's write it over here. We'll write why Av nodal contraction that is slower. Okay. Now try to understand. For that thing, I'll just draw the piece of the what Av node over here. If I draw the piece of the Av node, for example, in these portions. Okay. Now try to understand. At first, from the AC node, from the AC node, for example, over here, the electrical impulse will come within the Av node. Now we'll get within the Av node, we'll get within the Av node the myocardial cells. We'll get the multiple smaller myocardial cells. Where we'll get within the Av node multiple smaller myocardial cells. Now see, whenever the electrical impulse needs to cross the Av node to go to the ventricle, at that time if we see this electrical impulse needs to cross multiple membranes of the smaller cells. So first thing we can write it over here, for having the smaller size, smaller myocardial cells, okay. So as a result we will see the electrical impulse or the cardiac impulse that needs to cross multiple membrane, okay. Needs to cross multiple membrane is the one region. Now whenever it needs to cross the multiple membrane, definitely the time that will be the contraction that will be slower over here. Okay. Now the second thing is over here, as we know that in between for example is the myocardial cell. In between the myocardial cells, we know what there is a presence of gap junction, or we can see electrical window by which it will send the electric impulse to the subsequent cells. In these cases, we will get the very few gap junctions. If we get the very few gap junctions, definitely the conduction that will be slower, because if it can have the more amount of the electrical window or gap junctions, it will try to send the electrical impulse very soon. But due to the lacking of the electrical window or the gap junctions, or you can say the very few gap junctions is over here, as a result it needs to more time to send the electrical impulse from where? From the Av node to the ventricles. Okay. Now the third thing is over here. Try to understand from here that, okay, as we say that the size is less. As the size is less, so definitely the diameter that will be also less. Whenever the diameter will be less, definitely the cell that will face more resistance. Try to understand from the example. If we get if we get a pipe with the less diameter, and if we just try to push the water molecules through it, definitely the water molecules that will face the more resistance with compared to the large one. If you are having the large, if you are having the large pipe, if you try to send the water molecules, that will face the less resistance. But in these cases, as I said, that within the Av node, we will get the smaller myocardial cells. They will face more resistance because of what? Smaller size. So we can say the diameter that will be less. As a result face more resistance. They will face more resistance. Whenever the resistance will be more, definitely the conduction velocity that will be also less over here. Okay. The most important thing, the most important point, you have to remember this one. The resting membrane potential, potentials of the Av nodal cells, that is around minus 60 millivolt. Now try to understand. For example, there is a cell. Okay, I'm just taking the hypothetical. Let's erase this part. I'm just taking a hypothetical cell. Okay, is the cell. If I say the resting membrane potentials of it minus 60 millivolt, and definitely at that time whatever thing we will get, whenever the electrical, whenever the electrical impulse, the cation that will influx over here, for having the negative charge, there will be positive negative attractions. Whenever the positive cations they will come from the outside within the cells, definitely as it, within the cells we are getting what, the negative potentials. Definitely the cations they will get the influx of the cation within the cells. But for example, if I say another cells we are getting minus 90 millivolt. Now try to understand where the cations will move very fast, definitely within the minus 90 millivolt, because the more negative potentials, there is the less negative potentials. If we get in any kind of the cells, the more negative potentials, the influx of the cation, that will be very soon with compared to minus 60 millivolt. As I said, that within the Av Nodal myocardial cells will get the resting membrane potentials around minus 60 millivolt. That's why the cationic influx, that will be very slow rate. That will be in the very slow rate. So we can say in this cases the cations influx, that will be in the slow rate. So whenever it will come in the slow rate, definitely the depolarization, that will be also in the slow rate. Whenever the depolarization will be slow rate, definitely what we'll see in these cases, the delayed conductions. Now in these cases we will see around minus 60 millivolt at the time, the voltage sensitive sodium channel, they will be not able to work, they will be closed permanently. Okay, and in these cases we will get the activations of what, whenever we are talking in terms of minus 60 millivolt potentials, at the time the voltage sensitive calcium channels, that will be activated, and we see there will be influx of the calcium. As you know that the depolarizations that is done by the calcium, but at the slower rate. So in this case we will get the sodium channel, that will be blocked, but the calcium channel, the voltage sensitive calcium channel, that will cause the depolarizations in terms of the AC node as well as in the AV node. That's why you get a little slower conduction soil within these nodes, okay, in the AC node as well as within the AV nodes. So is calcium ion that causes depolarizations at the slow rate. So depolarization will get in these cases, depolarization at slow rate. Okay, so these are the reasons why we will get the slow conduction within the AV node. First we will get the smaller myocardial cells. Whenever smaller myocardial cells, the electrical impulse needs to cross the multiple membranes. As a result, it will take more time to cross all the membranes to send the signals or to send the the electric impulse from the AV node to the ventricles. The second thing is over here, there are presence of the very few gap junctions. So whenever we get the very few gap junctions, definitely the electric impulse needs to, the electric impulse, they will take more time to cross the all membranes, all the cells. Third thing, the diameter is more whenever diameter is less. Whenever the diameter is less, as the cells are smaller, definitely they will face the more resistance. Whenever the resistance will be more, definitely the slow, automatically that will be slower. Resting membrane potential is the most important, or I am just start marking it this on. This is the most important. The resting membrane potentials of the AV node is minus 60 millivolt. Okay, compared to the others, resting membrane potential will get in others is minus 85, minus 90 millivolt. Where the cationic influx, that will be more rapidly. Here the cationic influx, that will be in the slower pattern. As a result, the conduction, that will be also slower. Now we'll talk about, after that, whenever the the current or the electric impulse is held over here for 0.1 second, and it will help the atrium to contract completely and to get the atrium empty. Definitely the current that should be held for a while over here. Then we will get the complete depolarization of the atrium. Then the blood that will be sent from the atrium to the ventricles. Now we will talk about why we will see in these cases, as I said, that in terms of the bundle of Fitch, in terms of the Purkinje fibers, ventricular myocardial cells, we will get the first velocity. The reason for these things we will talk about right now. So for that thing, let's draw a piece of cells where within the I will talk about why we will get the more velocity, the fast velocity within the bundle of Fitch. So bundle of Fitch, why we will get the more velocity over here. Now if I just try to understand the bundle of Fitch, the Purkinje fibers, okay, the Purkinje fibers and the ventricular myocardial cells, all of these things are made up of Purkinje cells. Don't get confused with the Purkinje fibers. I am repeating once again. The bundle of Fitch, Okay, the Purkinje fibers, the ventricular myocardial cells, all of them are made up of Purkinje cells. Okay, that means the Purkinje fiber is also made up of Purkinje cells. The bundle of is also made up of Purkinje cells. The ventricular myocardial cells, they are also made up of Purkinje cells. Okay. Now, whatever the arrangement we will get in the Purkinje cells, as a result, we will get the more velocity, the fastest velocity among these three: SN node, AV node, and this part, the ventricles. Okay. Now, if we see, okay, let me show over here. In this case, whatever the cellular arrangement we will get over here, try to understand from this part. For example, is the cellular pattern in terms of the Purkinje cells. Okay. Now see, first things, they are the with the comparisons of these cells, definitely they are the large cells. So large cell. So cell size of the cells, that is large over here. Okay. The second thing is over here. Okay, let's show this one, the different color. Now see the cells. For example, as we know that what the depolarizations vector that will go down and leftward. See, whenever the depolarization is coming in these directions, in the same directions the cells are arranged. If we just say the orientations of the cells in the same directions of the depolarization. So if we say over here the orientation of cells along the line or along the direction of electrical impulse or the cardiac impulse. Okay, electrical impulse. So it will be very easier for the electrical impulse to go through the cells. So at that time we'll see the fast velocity in these cells. The second thing done. Now third thing, whenever try to understand, whenever the large cell is over here, definitely the resistance that will be less, as I said already before. Whenever the size of the cells that will be large, definitely the diameter that will be also more over here. So whenever the diameter is more, definitely they will face the less resistance. So whenever the resistance will be less, the velocity, conduction velocity, that will be more. The conduction that will be also more over here. Okay. Number 4. In between these cells, we'll get the more number of the gap junctions. In between these cells, we'll get more number of the gap junctions. Whenever we'll get more number of the gap junctions, the electrical impulse that will pass through the cells very rapidly because of what? Having the more number of gap junctions. So here we'll get number of the gap junctions that will be more. Whenever the gap junctions that will be more, definitely the velocity that will be also more. Okay. And the most important on over here, the resting membrane potentials of the cells. The resting membrane potential of the cells will be around minus 90 millivolt. We'll get the resting membrane potential of these cells around minus 90 millivolt. Now see from the figure, when we are saying, we compare to this one, we got the minus 60 millivolt. The potential resting membrane potentials for the Av nodal cells. Now if I say the resting membrane potentials for the Purkinje cells around minus 90 millivolt. Now try to understand, definitely at the time the cationic influx that will be very rapidly. We'll get the very rapid cationic influx. So in these cases, the voltage sensitive, calcium, sodium channel, that will be functional. So in these cases, we will see the voltage sensitive sodium channel, sodium channel, that will be functional. That's why we will see in terms of the Purkinje cells, the depolarization that will be what? Based on the voltage sensitive sodium channel. But in case of the SN node and the AV node, we will get the depolarization that is based on the voltage sensitive calcium channel, because the resting membrane potential for these cells is minus 60 millivolt, or we can say less with compared to the Purkinje cells. Okay. Hope it's clear for you, Claro. Now we'll talk about the normal ECG pattern, how we are getting this ECG over here. Okay. For that thing, I'll just show from here only. Try to understand from this figure. Now, if the normal heart over here, okay, let's erase this part for you guys. Now try to understand from this figure. Now I have taken the voltmeter over here. we'll get the fluctuations of the needles. Now, as I said, normally in the EKG part, whenever the AC node that will fire, at the time it will send the signals. It will send the electrical impulse within the atrium. So whenever the electrical impulse or the cardiac impulse that will be sent to the atrium, we'll get the depolarizations of the atrium. We'll get the depolarizations of the contractions of the atrium. As a result, we'll get what? As a result, we'll get productions of the PO. For example, at the resting conditions, there is no activations of the heart. Normally what? If you see the ECG pattern over here, okay, let's so in this way, okay, normally. No need to draw the ECG paper, I'm just showing you here over normally. Okay, first we'll get normal, there is no activations of the heart. No activation of the heart. Now see, whenever the as AC node is firing, whenever the AC node is firing, it is sending the signal or it is sending the what? Electrical impulse or the cardiac impulse within the atrium. As a result, we'll see there will be depolarization of the atrium. They will produce the POF. Okay. After after getting the POF, whenever the current that will come within the AV node, and within the AV node, I have already said that the current that will be held for 0.1 second. Within the AV node, the current that will be held for 0.1 second, okay, for the complete atrial contractions. As a result, whenever the current will be held over here for 0.1 second, there will be no fluctuation of the needle. That will be what? We'll get a straight line. So try to understand from here. In these cases, we'll get a straight line. Okay, we'll get a straight line. So we got the POF. Then we got over here. Try to understand. We got for the first. We'll get in these cases. During the atrial contractions or atrial depolarizations, we got a vector with a moderate velocity. We got the vector with a moderate velocity over here. So, moderate velocity or distance of the vector that is moderate. Now see, it is going, okay, for that thing, let's draw this part. I have to draw this part, then it will be more clear for you guys. So, for example, let the one point is another point, okay. I'm taking it's the positive, the bipolar limb loads is the negative part. Now I'm connecting these two sides with this one. Now I'm connecting these sides with this one and this positive side with this one. Okay. Now it will be the what? It will be the lead of axis. It will be the lead of. It will be the lead of axis. Okay. Now try to understand from here. Whenever the electrical impulse is coming from the AC node to the within the atrium, then we are getting the atrial contractions. And whenever the atrium is going under the contractions, we are getting productions of a vector. This vector is going what? From negative to positive. That means the positive vectors is going towards the positive. But as I said, with the moderate velocity, we will get what? The here that will be moderate also over here. After that, whenever it will come within the AV node, whenever it will reach to the AV node, the current that will be held for 0.1 second. As a result, we will get there will be no fluctuations of the needle. It will be straight line there, just normally. And after that, whatever the thing we will get, try to understand from here. We will get the septal depolarizations. We will get what? Septal depolarizations. And within the septal depolarizations, we will get the vector. We will get the vector over from here. So during septal depolarizations, we will get the vector that will be produced, and that will go from what? From the positive sides to the negative side. That means the positive vectors that is going towards the negative side, the negative pole. The positive vector that is going to the negative pole. As a result, and this vector that will be not that much stronger for the septal depolarizations. So we'll get less stronger vector. That's why we'll get what over here. We'll get the definitely negative fluctuations because the positive vector that is going towards the negative pole. So as a result, we will get over here the negative fluctuations of the needles. After that, what type of thing we will get over here? See, after that we will get what? The major ventricular depolarization. We will get the major ventricular depolarizations. So in this way, we will get the major ventricular depolarizations. Now in these cases, try to understand these positive vectors. The positive vector that is coming towards these positive sides. So in these cases, we will get a stronger vector. Definitely within the ventricle, always we will get the stronger vectors over here. So as a result, we will get the productions of the QRS complex. Okay, we will get the productions of the QRS complex over here. After that, see, we will get what? The basal depolarizations. After the major ventricular depolarization, we will get the basal depolarizations from the base. Now in these cases we will get the positive vectors that is going from the positive sides to the negative, that means right and upward, it is going right and upward. So as a result, again we will get our negative depolarizations. That means at first we will get the QRS complex, after that we will get this one, it will come to the again for the negative. Okay, then after that, whenever the ventricular depolarization will be completed, that will be completed, we will get what? The repolarization of the, we will get the repolarizations of the ventricle. At that time we will get the here basically we will get what type of thing? Here basically we will get the negative vectors. Whenever the repolarization, definitely the depolarization is getting neutralized. So whenever the repolarization, that means definitely the negative vectors, so the negative ones, that will go towards the negative. Whenever the negatives is going towards the negative, that means that will be also the positive reflections, as I said earlier in the EKG part. Okay, so we will get what here also. After that, basal depolarizations, the heart, that will be that there will be no activations of the heart for a while. Then after that we will get what? The repolarizations. For that we will get what? The T wave. This T wave we are getting, try to understand, this T wave we are getting for what? This T wave we are getting for the repolarizations. And as the negative things or the negative vector is going towards the negative pole, as a result we will get the positive reflection. That's why this positive part over here. And from the ventricle, that's why we will have a little bit more stronger vector. Okay. Now we'll talk about the Av Nodal arrhythmia. Okay, Av Nodal arrhythmia or the junctional arrhythmia. Okay. Now try to understand from here. Okay, let's draw this part with a different color. From here to here, we got a line that is known as what? Pier segment. Now see, during the pier segment, actually it is supposed to be called as the PQ segment, but in most of the leads we have gotten already. Sorry, in most of the leads we got that the absence of the Q wave. It is supposed to be known as what? The PQ segment, but in most of the the limb leads we got the absence of the Q wave. That's what is known as pier segment. Now the pier segment, in these positions we are getting, there is no fluctuations of the needle. That means the current that will be held within the AV node. So we will get the pier segment for the AV nodal slower conduction. Within the AV node we will get the slower conductions. As a result we will get the pier segment over here. Now another thing over here we need to know, that the pier interval. So what is the difference in between the pier segment and the pier interval over here? Okay, let me show for it. Once, wait a minute please. Okay, let's continue. So pier interval and the pier segment. Now see, try to understand. Pier interval means, okay, it will also take the what? Atrial depolarizations, along with that what? The AV nodal depolarization, the AV nodal conductions. So in these cases, try to understand, within the pier segment we will get this part, the P wave, that is responsible for what? Causing the atrial depolarizations. So we will get over here, what type of thing we will get? We will get over here the atrial depolarization plus we will get what? We will get also the pier segment. This pier segment we will get what? There will be no electrical fluctuations, because of what? Because within the AV node we will get the slower conductions, and that will be not able to fluctuate the needle in any directions. Okay, that's why we will get a straight line over here, that is known as the pier interval. And the pier segment we will get what? The current within the pier segment, I have already said. Why will get the pier segment? The pier segment over here, we will get what? The electrical impulse or the current that will be held for 0.1 second within the AV node. Okay. Now we will talk about what are the changes that can cause, if we get, for whatever regions, try to understand, for whatever regions if we get, if we just make the AV node slower, for whatever, try to understand what I am saying, for whatever regions, it may be the drug related, it may be, for any kind of the shock, if we get the the PSA with the that sorry, if we get, try to understand, if we get the AV node that is becoming slower, that means if we get the conductions within the AV node that is slower, for whatever reasons, if we get the conduction within the AV node that is slower, or slower conductions of AV node, normally it is slower, but if you get more than slower, that will be regarded as what? Nodal or junctional bradyarrhythmia. So now, for example, if we use any kind of the drug, for example, if we use the beta blocker, if we use, for example, the adenosine injections, that is the most powerful, adenosine, or if we use the calcium channel blocker over here, that will make the AV node more slower. That will make the AV node more slower over here. Now, if we see the AV node is becoming more slower, definitely what? Here the the segment, the PR segment, that will be what? Extended. Will get, in these cases, we will get the PR segment. The PR segment that will be longer. The PR segment that will be longer. Try to understand. We are making the AV node slower, more slower. Whenever we are making the AV node more slower, definitely the PR segment where the AV node is actually found, for what we will get the AV node. See, whenever we make the AV node more slower, definitely we will get the PR segment that will be more longer. Whenever the PR segment that will be more longer, definitely along with that, it's quite logical that we will get what? The PR interval that will be also longer. PR interval that will be also longer over here. For whatever reasons we can make the AV node more slower, definitely this type of thing will get over here. Now let's show you with these things with the different kinds of the aspects. Okay. Now, if we use for any kind of the things that will make the AV node, okay, let's write it over here, then I am explaining also. So if you use, let's repeat once again, if you use any kind of the drugs that will make the AV node more slower, definitely the PR segments or the PR interval, whenever the PR segment that will be extended or the longer, definitely the PR segment that will be also longer, because PR interval is nothing but the atrial contractions plus the what? PR segment. So whenever the PR segment will be longer, definitely the PR interval that will be also longer or extended. Now if we use any kind of the thing, for whatever reasons, if we the AV nodal conduction, if it is increased for whatever the reasons, for example, if someone takes the caffeine, and we know that within the caffeine what? They are phosphodiesterase inhibitor. Whenever they are inhibiting the phosphodiesterase enzyme, definitely they will increase the cyclic AMP, and whenever the cyclic AMP that will be increased, definitely they will activate the kinase A. So whenever the phosphokinase A that will be activated, that will do the phosphorylation of the calcium channel. So phosphorylation of calcium channel. So whenever the phosphorylation of the calcium channel that will be done, definitely the extra amount of the calcium channel that will come to over. So whenever the more amount of the calcium channel is over there, definitely the depolarization that will be very fast. So whenever the depolarization that will be very fast, definitely within the AV node, the conductions, the velocity of the AV node that will be faster, the conduction that will be faster. So whenever the conduction that will be faster over here, conduction faster. So whenever the conduction that will be faster, definitely the PR segment that will be shortened. Whenever the conduction is faster, definitely this will be not that much, it will be shortened. So we can say that PR segment that will be shortened. As a result, we will also get what? The PR interval that will be also shortened. It's quite logical, okay? That will be also shorter over here. Okay. Now we'll talk about the different kinds of the aspects by which whatever the thing. First we'll talk about the junctional bradyarrhythmia. Then we'll talk about the junctional tachyarrhythmia. Okay. So let's talk about the junctional bradyarrhythmia first. So let's talk about the junctional bradyarrhythmia. Whatever the ECG will get over here, or whatever the regions, we'll talk about those things. Okay. Now junctional bradyarrhythmia. Let's write it over here. junctional bradyarrhythmia, or another name for it we can say, okay, that the nodal arrhythmia, or you can say the heart block. You can say the heart block. Now we will talk about these things, the junctional bradyarrhythmia or the nodal arrhythmia, or you can say the heart block over here. The same thing in different names, okay. Now we'll talk about these things over here first, okay. Normally, what do we know? Normally, for example, it's the Av nodal part. It's the Av nodal part. What do we know in the Av nodal part? That first from the AC node, the impulse will come over here, and that will cause the depolarizations. Again, it will go back to the right. It will be sent to the ventricles. In the same, if we get it over here, it will go to the depolarization. It will go where within the ventricles. Again, from the AC node, it will come over here. It will cause the depolarizations. Okay, first we'll get what? These depolarizations of the Av node followed by the what? QRS complex. So the depolarizations of the, try to understand depolarizations of the Av node, that will be followed by the what? QRS complex over here. Now if you draw the ECG pattern for it, what we will get over here? Try to understand. For it, we will get normally we get the POF, okay. Then again we will get the QRS complex. Again we will get the TOF. Again we will get what? POF. Again we will get the QRS complex. Again we will get TOF. Again we are getting the POF. Again we will get the QRS complex. Again we will get the TOF. Normally, okay. So under normal circumstances, if we see this is the Av node, if we just consider this the Av nodal part, it is considered the Av nodal part. From the AC node, the electrical impulse is coming, the cardiac impulse is coming. It is causing the depolarization of the Av node. After that, it is again sent to the wire within the ventricles for producing the QRS complex over here. So we'll get over here the POF. We'll get the QRS complex. We'll get TOF. So we'll get again the POF. We'll get QRS complex. Let's do it. QRS complex, again TOF, we will get POF, QRS complex, again we will get the TOF in this way. That will continue, okay. Now for any regions, if we just treat any kind of the patients for a congestive heart failure, we are using the beta blocker. So whenever you are using the beta blocker, okay, so normal dose of the beta blocker, for example, if we say that, okay, let's draw it first, then I am saying it once again. For any kind of the conditions for what we are supposed to use the beta blockers, or we can say the here the calcium channel blocker, when you are supposed to use in these cases, try to understand from it that first again whenever you are using the beta blockers, that will make the what? Av node slower. That will make the Av node, the conductions of the Av node, that will be more slower. So for whatever the regions we are getting the first we are getting the AC node, from the AC node the impulse is coming. Then okay, let's do it. Okay. Let's make it a little bit larger, then I think it will be easier for you to understand, because this time I have to say a little bit more thing. Okay, now is the Av nodal part. It is the Av nodal part. At first from the AC node the impulse is coming. Whenever we are using the beta blockers, definitely they are just inhibiting the Av node. That means they are just reducing the conduction velocity of the Av node. As a result, the depolarizations of the Av nodal, that will be for longer durations. Again, it will go back to the ventricles. In the same way, again we will get these things. Again, the what? Depolarizations of the Av node, that will take more time. That again it will go back to the ventricles. Again the same way. So in these cases, whatever the thing we are getting, whenever you are using the beta blockers, see the Av nodal velocity, the conduction velocity within the Av node, that is getting increased. So whenever it will be increased, whenever it will be decreased, when you are using the beta blockers, so whenever you are using the beta blockers, the conduction velocity within the Av node, that will be slower. So whenever it will be slower, definitely try to understand the PR segments, or whatever you can say in terms of the PR interval, that will be increased. So in this case, whatever the graph we are supposed to get, okay, in these cases we will get the POF, okay, and in these cases try to understand, we will get longer duration, we will get the extended what? PR interval of the PR segment, and again we will get the QRS complex, again we will get TOF, again we will get what? POF, again we will get for longer durations the the PR interval of the PR segment, again we will get QRS complex, again we will get the TOF, again we will get the P wave, again for longer durations we will get the segment of the PR interval, then again we will get the QRS complex, again we will get this type of thing. Now try to understand from here, what did I say? So that in this case is the PR segment or the PR interval that is what getting increased. Okay, so the segment, PR segment or the PR interval that is getting increased for using the beta blocker. Okay, with a little dose. Now if we use, for example, if we increase the dose of the beta blocker, blockers, okay, now let me show over here, it will be more easier for you. Okay, now try to understand from here. If we use the beta blocker with the normal dose, that is squat, that is increasing the PR interval, the PR segment. Now this thing is known as primary heart block, or you can say primary nodal block. Okay, we can say primary heart block or primary nodal block. And the second case is, if you increase the dose of the beta blockers or the calcium channel inhibitors, whatever the thing will get over here. Let's show this part. The second part I'll show you. If we increase the dose of the beta blockers a little bit more than the previous one with respect to this one, whatever thing will get over here. Okay, let's show it more clearly for you guys. If we increase the dose of the beta blocker, whatever the changes will get over here, that I need to show you. For example, we'll get in these cases, whenever we're using the beta blocker, dose of the beta blocker, we're increasing with respect to this one more. Now in these cases, try to understand first from the AC node. Okay, the electrical impulse is coming, it is going under the depolarizations, again it is going back to the ventricles. We'll get some, some electrical impulse that will come from the AC node, but that after coming within the AV node, we will not get the the depolarization AV node. That will not get the depolarizations of the AV node. That will not do the depolation of the AV node. As a result, we'll see that will not be the QRS complex. That will stay over here. Again, we are getting another kind of the electrical impulse that is coming from where within the AC node, coming to the AV node. Then again we are getting what the AV nodal depolarizations. Again we are getting the QRS complex. Now try to understand, if we increase the dose of the beta blockers, we are getting the some electrical impulses that are coming from the AC node to the AV node. After causing the depolarizations of the AV node, they are going back to the ventricles. Now we will also get some types of the depolarization within the ventricles, within the AV node. This depolarization that will be stay within the ventricle, within the AV node. That will be not followed by the QRS complex. Now in this case, whatever the ECG pattern we will get, try to understand from here. We will get for the first vectors, we will get for the first depolarizations things over here. Normal, you will get normal, P wave. Now we will get the normal P wave. We will get again the normal QRS complex for the first one. Again we will get the P wave. Now see, in these cases there is the absence of the QRS complex. We will not get the QRS complex. As a result, we can say these things, there will be absence of the QRS complex. So we can just show the line. Again after that we will get the P wave. Okay. So again we will get the QRS complex. For these things it's the normal way. So again we will get the QRS complex. Okay. Again we will get the T wave. Again we will get the P wave. Again we will get the QRS complex. Again we will get the P wave, for example. Now in these cases, see, whenever you increase the dose of the beta blocker, we will get the some waves that will come from the what? From the AV node to the ventricles normally. And we will get, there will be some depolarizations vectors, or you can say the electrical impulse that will come from the AC node to the AV node. But when the AV node will be that much slower that it will not be able to send the electrical impulse from the AV node to the ventricles. As a result, we see there will be the absence of the QRS complex. For that region, we will get there will be extended PR interval, or you can say extended PR segment over here, because of the absence of the QRS complex in these positions. So we can say over here, if we compare the number of the P, okay, let's so Q, R, S, T, and again we get the P, we get the Q, R, S, T, we will get again P, Q, R, S. Okay. Now see, in these cases we will get the P wave, we will get the Q, R, S, we get T, we will get the P wave, Q, R. Let's erase this part, guys. Q, R, S, Again we will get the T wave. Now see, in these cases, if we just compare, the number of the P wave and the number of the QRS complex. In these cases, how many P waves we are getting? We are getting the 3 P waves. 1, 2. Okay, let's make one more P wave. Okay, now see, we are getting 1, 2, 3 P wave. Now how many QRS complex we are getting over here? We are getting the 2 QRS complex. We are getting the 3 P wave and we are getting the 2 QRS complex. That means the AV node is becoming so much slower that is not able to send the electrical impulse from the AV node to the ventricle. So whenever the electrical impulse that will be not sent from the AV node to the ventricle, definitely there will be no productions of the QRS complex. So what's the reason for it? Definitely within the AV node, the conduction velocity is so less that it is not able to send the electrical impulse from the AV node to the ventricles. So this type of thing is known as secondary heart block. Now this type of thing is known as secondary heart block. Heart block. Now we'll talk about another most dangerous one, the third degree heart block. For that thing you have to draw a little bit more. Okay. Okay, let's show over here only. No problem. I can show over here. Now, for that thing, if we increase the dose of the beta blocker too much, you have increased the dose of the beta blocker so much that it will stop the AV node for a while. If we increase the dose of the beta blockers, or if we give the injections through the intravenous route, the adenosine, if we inject the adenosine through the intravenous route, that will stop the AV node for a while, for a few seconds. Whatever the changes we will get in this case, try to understand from this figure. So if we, okay, let's do a little bit below, then I think I can show it. Okay. Now see, in these cases we have increased the dose of the beta blocker. So in these cases we have increased the dose too much. Whenever the dose we have increased too much for the beta blocker or the calcium channel blocker, or we have injected the adenosines over here, adenosine. So whenever we are injecting the adenosines, it will stop the AV node for a few seconds. It will just cause what? It will stop the AV node for a few seconds. Now try to understand, whenever it will stop the AV node for a few seconds, whatever the things will get from the SA node, definitely from the SA node, no problem. The electrical impulse will come, and it will see there will be depolarizations of the what? AV node, but there will be no proper depolarizations of the AV node. That will be send the electrical impulse from the AV node to the ventricle. So in the same way, here we will get again. It will come over here. It will be not able to send. That means they will never go from the AV node to the ventricles. Again, we will guess whatever the thing will get over here. In these cases, so there will be no electrical impulse from the AV node to the ventricles. Now from the SA node, if we see from the SA node the signals were coming in. Now if you consider that from the SA node, the beats was around 80 beats per minute. 80 beats per minute. Now in these cases, as I said, there will be no depolarizations within the AV node. As a result, there will be no there will be no sent. There will be no any kind of the vectors or electrical impulse that will be sent from the AV node to the ventricles. Now try to understand from here that, see, as a result we will see the development of the another pacemaker. We will get the development of another pathological pacemaker within the AV nodes. Okay, apart from the AV node, we will get another what? Pathological pacemaker. Pathological pacemaker over here. So it will try to send the signal or try to send the what? Electrical impulse from these portions to the ventricles. From these portions to the ventricle. So for example, 40 beats per minute, around 40 beats per minute. Definitely you will get what? The bradyarrhythmia. And in these cases, if I just draw, you will not get there will be total absence of what? There will be total absence of the QRS complex. Now if you draw it over here, whatever the thing will get over here, try to understand it will be the P wave. You can see there will be no QRS complex. Okay, there will be no QRS complex. For example, we will get the T wave. Again, there will be no. Okay, again we will get what? The P wave. Then again we will not get any kind of the QRS complex. Again we will get the T wave. Again we will get what? P wave. No QRS complex, just like this. So in this case, try to understand from this figure, the QRS complex that will be totally absent over here. QRS complex totally absent. QRS complex totally absent. QRS complex totally absent. It will be absent over here. Now this type of thing is known as third degree heart block. third degree heart block, or you can say the complete heart block. Complete heart block. So in these cases, we'll get what the complete heart block. That means in these cases, within the AV node, the conductions within the AV node, that will be less. We can see there will be absence of the conductions of AV node over here. For whenever you're using the drugs, for example, the adenosines, by the injections through the intravenous route, definitely it will go over here. It will block the AV node for a few seconds over there. So this type of thing, as far as the junctional bradyarrhythmia is concerned. Now in the second part of the video, we'll talk about the junctional tachyarrhythmia. What type of the thing, what type of the clinical manifestations, and what type of the ECG you will get over here. We'll talk about these things in the next part of the video. Okay, so please do subscribe my channel, and please let me know if you don't understand any point for my speech or whatever the reasons. If you don't get any point, please let me know in the comment sections. I'll read your comment and I'll try to help you guys with my level best. Okay, so see you in the next video soon. Thanks for watching.